Namaste. Greetings from India. I am proud to work at the Father Muller Medical College, which hospital had been established in 1880s by the German Jesuit priest Reverend Father Augustus Muller. This is the layout of our institution. This chapel is the powerhouse of our institution. I would like to confer with you on this study, comparative pharmacokinetics and compliance issues to optimize antiretroviral therapy. My co-authors are Manasa, Sana and Ashwini. As we see, the major cases of HIV in Asia are on the Indian subcontinent. It is heartening to note that the frequency of AIDS infections have reduced despite the projected values to 22.7 lakhs in 2008. Maybe this is due to the rampant use of a simple latex device. The Government of India, along with the World Bank, has a minimalistic interventional plan, the goals of which are early initiation of therapy, quality, effective medical care, and preventive measures. The Government of India plans to finance 40% of the Indian HIV infected persons, that amounts to a whopping 2.1 million. On this study, we embarked on a small-scale study of 83 sample size using an investigational cross-sectional design. We recruited the patients who were previously ART naive, presently on ART therapy of either sex, 20 to 60 years of age, and who are not bedridden. We have recorded their history, the examination, the treatment that they received. We conducted a one-time investigation of random blood sugar, liver function tests, hemoglobin, CD4 count, and lipid profile. We also inquired into their ADR. We also took the prevailing quality of life scores using the WHO questionnaire, quality of life questionnaire of the short version. We also did a literature survey on all the pharmacokinetics of the presently available antiretroviral drugs. The results. The demographic details are as usual. The treatment characteristics are noteworthy. 53% of our sample size have initiated their therapy at 6 months to 1 year. There were about 38% of our sample size who are infrequent defaulters. The motivators for regular medication in about 55% of our patients were counselors and NGOs. In fact, hereabouts we have the positive people who work in concert with the governmental authorities to achieve better motivation for regular medication. If we see the CD4 counts, before initiation of therapy, we have categorized it into two. The first group 200 to 300 and the second 100 to 200 cell counts. We have noted there are 4 of the readings and plotted on this graph, which shows a steady dip after initiation of therapy. Now this is purely either coincidental, spurious, and not mentioned by any other researchers in this field. So it is still unknown, or maybe a spurious effect. 53% of our patients show at least 3 to 10 adverse effects at a given time. The commonest antiretroviral therapy regimen that 65% of the sample used were stavudine, lamivudine, and nevirapine. The commonest adverse effects are insomnia, headache, and abdominal pain. The concomitant drug group that is most commonly used are the antibiotics, followed closely by GIT drugs and cardiovascular drugs. The quality of life scores. We see the mean transformed scores. The physical domain showed better quality of life scores as compared to psychological, social and the environment domain. Now coming to the discussion. The effectiveness of antiretroviral therapy is seen through the virologic failure as well as the immunologic failure. Viral blips are rarely seen. In fact, the literature survey done on the pharmacokinetics of each of the individual agents show that the individual pharmacokinetics are conducive to the combination therapy. In fact, the low cost of nevirapine precludes all other disadvantages and even used along with anti-tubercular therapy. Hence, our recommendation would be, as other researchers would also agree, that CD4 count guided structured treatment interruption would reduce the pill burden, the cost factor, allay the resistance and reduce the adverse drug reactions. The limitations of a study are it needs an in-depth study including more patients, it needs therapeutic drug monitoring and pharmacogenomic markers to be more effective. Hence, to conclude, despite the presence of a horde of antiretroviral drugs, there is drug resistance, compliance issues, cost factors that limit ultimate therapy of AIDS. Hence, we discussed and we come to the conclusion that structured treatment interruption, well manipulated by CD4 count appraisal, would be the answer to effective and optimal antiretroviral therapy. Thank you for a patient listening.